Welcome, everyone, to today's webinar, How Incorporating New and Complex Procedures Can Bolster Your ASC's Bottom Line. I am Laura Dierda, an Editor-in-Chief with Becker's Healthcare. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used in to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Nader Sami is the Chief Executive Officer of National Medical and has guided the company into its position as the largest and most reputable revenue cycle management company in the ASC market, with over 250 surgery centers in 35 states. Nader leads the company's strategic direction with a strong emphasis on exceptional client services, lean and efficient processes, cutting-edge technologies, and insightful analytics. Prior to National Medical, he served as a corporate finance attorney at a 400-member law firm, and he has experience as an investment banker. Nader is currently a member of the Public Affairs Committee for the Ambulatory Surgery Center Association, as well as an active member of the Healthcare Financial Management Association. Scott Allen joined National Medical Billing Services in 2008 and is the Vice President of Managed Care Contracting. He manages all aspects of ASC managed care contracts, which include the analysis of language and rates, contract audits, and developing best practices for implementing standard operating procedures for the managed care contracts throughout the revenue cycle. Scott is heavily involved in the ASC industry through a variety of advocacy roles. He serves on the Payer Relations Committee of the Healthcare Billing Management Association and has lobbied on Capitol Hill for the Ambulatory Surgery Center Association. Scott is also a frequent contributor to the industry publications, writing about managed care contracting and other ASC topics. At this time, I am pleased to turn the floor over to Nader to begin today's presentation.
Thank you, Laura. Scott and I are really excited to be here today as we find this is one of the most interesting times for the surgery center space. There are macro trends that are really driving more and more interesting and complex procedures into the ASC setting. And this is really a tremendous boon for patients, for providers, and for payers as it's taking significant costs out of the healthcare system. So with that, what we are going to discuss today are these big picture trends and highlight certain specialties and procedures that are actively moving into ASCs, and also discuss the steps required to capitalize on this opportunity and then to demonstrate the financial impact of these types of cases and capitalizing on the opportunity. So with respect to the trends that are really moving these procedures into the ASCs, as we kind of look at this, it's really, there are three primary constituents here. You have patients, you have the providers, and you have payers/employers. And in this case, all three, it's really a win-win-win in terms of the movement to surgery centers. So it's rare in life that you get all three constituents that have the same ultimate, goal and objective here. And so from a patient standpoint, it's highly personalized attention, it's a lower cost setting, and there's great outcome. You're minimizing going into a hospital and into that type of a setting where there's potentially, other illnesses and potential infections and such. So it's generally kind of a visit, healthy environment to be in. From the surgeon standpoint, there was a study recently done that showed that 60% of all surgeons that are not operating in ASCs want to be operating in ASCs. So you, one, have a significant amount that already are, and two, the vast majority who aren't want to be. And the primary reasons for that is it provides them with greater control of the staff in their OR, greater opportunity and easier scheduling and flexibility, and of course, very importantly, the opportunity to have equity ownership in the facility and to provide, that financial benefit that doesn't exist when they're performing the cases in the hospital. So really from a surgeon standpoint, it's really a tremendous opportunity and great, like I said, schedule flexibility and convenience. From the payers and employers, there's a major movement, as I think many of us have seen, to obviously big picture cut healthcare costs, and in this environment where you have procedures that can be performed, from a high quality and with great outcomes and safety perspective, if it can be done in a setting that's 30 to 50% less from a cost standpoint, then obviously that's very attractive. So there's billions of dollars of annual savings happening today, and many billions that there's an opportunity for additional savings. And so those are really three main drivers here. There is at times a little bit of pushback maybe from the hospital environment because they're losing some very big and profitable cases, but generally what we've seen, 25% of surgery centers today have health system ownership, and so most of the health systems are embracing and understanding the future of the healthcare delivery in the surgery center market, or the surgery center, placed within that market. Also, in terms of big picture macro trends, you have an aging patient population, but it's also aging in a healthier way. So you're increasing the number of surgeries that are required with the aging population, but also increasing the number and the percentage of those of that elderly population that can still be able to go into an outpatient setting for these kinds of procedures. So, you've got technology that is advancing every single day, and we're seeing that where now you've got total joints, you've got stents, you've got some of these different high complex procedures that never would have been able to be done, and now you look at total joints and people are going home, going in the morning and going home by lunchtime, from those kinds of procedures. So amazing in terms of the technological advancements that have allowed and are going to continue to allow for more and more of these complex procedures to move into an outpatient setting. Again, from a safety and outcome standpoint, all data that we have seen out there, point to very, very strong, safety and outcome, lower post-op stays, et cetera. And then finally, Medicare is on board and is continuing to move forward. We've just, like I said, seen the total knees be approved for 2020. We've got angioplasty and stents coming in 2020, and we continue to see every single year, there's high likelihood that knees are coming, that hips are coming soon, as they've been taken off the inpatient only list. So again, there's the CMS, obviously a guide and a good indicator as to what's coming with respect to the market and what's going to be approved. So those are all a lot of the macro trends that really are driving the aggressive growth in the surgery center market. So with that, let's jump into some numbers that show what this growth is. And so, this slide here is showing that if you look at what was performed in surgery centers in 2015 and what's going to be performed in 2021, you have $15 billion of additional revenue that is coming into surgery centers. So that obviously demonstrates an enormous opportunity from a financial impact to your surgery centers, $15 billion, and we have under 6,000 surgery centers in the entire country. That number is going to be disproportionately taken by the folks who are a little more cutting edge and progressive with respect to some of these higher acuity type of procedures. And so that's 54% growth from a revenue standpoint. You're looking at 20 million procedures in 2015 that have grown to 27 million in 2021. And the overall market is projected to grow at 7% over the next 3 years, as compared to 4% over the 3 years prior to that. So it's nearly double from a big picture overall ASC market standpoint. And then what we look at here is what are the hyper growth areas? And today, some of the hyper growth areas we're going to talk about are ortho, spine, and cardiology, as they're at the top of the food chain from a growth standpoint. So as we look at here, what this slide shows is that orthopedics is a more mature audience and industry from the standpoint of what's being performed in surgery centers. This is showing that 44% of ortho procedures were performed in surgery centers in 2015, and that's growing to 68%. And if you look at spine and cardio, only 7% and 4% were performed in 2015, so a much smaller percentage. But when you look at it from a growth standpoint, you're going to go to 68% in ortho, and basically a third of the spine and cardio cases are going to be done there. So you're looking at 31%, 200 and 230% growth rates over that, and this is from 2018 to 2021 are those growth rates. So dramatic growth in those areas, and not to be lost in this, and we'll get into this in a little bit, is that these procedures pay dramatically higher on a cash per case basis, and our experiences is from a overall margin perspective are much more profitable too than a lot of the cases that have historically been in surgery centers and are lower reimbursing relative to these cases. So while we could go into depth into various of those different interesting procedures that are moving, this particular slide is, I think, demonstrative of what these other areas will show. And so this is specific to just hips and knees. And what's really interesting here is this shows that from now till 2026, there's going to be an additional $9 billion in revenue generated by surgery centers only from hips and knee total replacements, just those two things. Because what's happening is the growth of, again, we talked about the aging population. Today there's 900,000 hip and knee replacements happening. That's going to double to 1.8 million. So not only are the overall number of these procedures are doubling in that time frame, but you also have a situation where 15% of those procedures today are being done in an outpatient / an ASC setting essentially, and that's going to grow to 50%. So you have the double of the population because of the aging, and then you have, with all the technological advancements, a movement from 15 to 50+% of those cases. And we're seeing a lot of activity. If you looked at in 2014, there were only about 25 centers across the country that were performing total joints, and that's up to 250 today. And based on just sort of anecdotally being in the market, that's growing every day. And those 250 that are doing them are still only doing a small percentage of what they can do. This Medicare movement obviously is going to be quite interesting. One of the challenges with Medicare's approval is that they approved it at what I think we would consider a low rate, and so it's going to be interesting to see how aggressive the movement is at $8,600 per total knee, for example. So I think stay tuned. The market will probably be evolving from a pricing, there's going to be a lot of movement that has to happen to be able to do those at that rate, and hopefully that rate comes up here over the next year or two. So to get a little bit more specific on the kinds of procedures, now this is not an exhaustive list, but this is a representative list of the types of orthopedic procedures that are being performed in ASCs. And historically, historically you've had, rotator cuffs, labrum repairs, Achilles repairs, those types of things have existed. And if you look at those, reimbursement, what we've listed over here too, by the way, is what Medicare allows, and then, utilizing a range, kind of an estimate or a range. Obviously, these numbers aren't exact. Every contract's going to be different. One thing Scott's going to jump into and talk about later in this presentation is you need to make sure that your contracts speak to these, that they're addressing them, that they are providing for a particular rate and then making sure that it's a rate that you're comfortable with after you've done all of your homework. But interesting, the total knee, for example, is one of the new ones that is approved per CMS. Now, those have been happening, with commercial payers over the last few years and in increasing numbers. But again, this is just to give you a feel, as we talked about the kind of reimbursement. If you sort of look at multi-specialty centers across the country that maybe are in the $2,000 cash per case range, you're looking at numbers that are here on the low side of, $3,000 and $4,000 up to $20,000 for these kinds of orthopedic procedures. So on the spine side, it's the same concept here, in that this is representative, not exhaustive, but there's been a lot of movement. There were 30 or 40 surgery centers in the country doing spine at all about 4 years ago, and we're up to 145 today. And now you're seeing things like spinal fusions happening in a surgery center. And, actually from a personal standpoint, I actually had one and had it in a surgery center, and it was a tremendous experience. It was great personalized attention. I was the only one who was there. It was actually an overnight stay. And it was myself, it was 2 nurses and a sheriff, and that was it. Overnight, had great attention. Their reimbursement was tremendous, for what ended up being about an hour and a half procedure, and yes, I was there for the night. So it's an interesting movement. But again, we listed here, from ACDFs to spinal fusions, to disc replacements, et cetera, but these are the kinds of things. And again, if you look at the reimbursement, you're looking from, again, $4,000 to $15,000, $20,000, and certainly you will see certain spinal cases, again, Scott will get into this, that are even better than that from a reimbursement perspective. So these are real needle movers. And if we flip to the next slide, same idea. Cardiology is probably the newest and the least mature of these specialties we're talking about today. And what we've seen over the last few years is, the insertion and removal of pacemakers starting to move there. The same thing, the insertion and removal of defibrillators and loop recorders. And so those areas have really grown over the last few years. In 2019, 12 cardiac cath procedures were added to the ASC payable list. And just now in 2020, CMS approved 6 stenting and angioplasty procedures. So really interesting time. I would say, again, anecdotally, we see this on the very early stages, very nascent for the cardiology centers. There are, at times there's some additional challenges in terms of additional build out. We've seen the hybrid office-based labs with ASCs where it's potentially, 2 days as an OBL and 3 days as an ASC or vice versa. So you're seeing different models in this arena. But again, if you look over to the far right, really solid reimbursement. The cath, around $2,000, but everything else significantly higher than that. So
now, if I can add to that, I think you're right. The reimbursement looks fair, but we have to be mindful of that if you're an eye center that wants to bring in ortho tomorrow, the reality is that your contracts are probably not designed for that sort of reimbursement. So you may not receive that estimated outcome.
And so, that was really, big picture, what's happening in the industry, what are the opportunities in terms of, as you think about if you're sitting in a boardroom and trying to strategize on where do we go, how do we build our ASCs, how do we think about, moving the needle from a top line and a bottom line perspective, faster, who are the surgeons we should recruit, how do we use our OR times. That was big picture designed to sort of get the thoughts moving and identify what's happening from that standpoint. Jumping to this next slide, these are really the steps that we look at as to if this is the path, let's say you're already doing a little bit of it or you want to engage and pursue this path, what are the steps as an organization you really need to consider? And look, every one of these ladders here could be almost their own presentation. So we'll try to be brief in hitting on this, but number one is making sure that you're developing really solid clinical protocols. And so, one is selecting the right patients, making sure, that, from the standpoint of their age, their BMI, their health history, disease history, et cetera, all of that it lines up and that you've been very thoughtful about, who are ideal patients to be able to be served and taken care of in a surgery center. And then thinking through, what are the best practices, developing or working with someone to develop a best practices playbook from the clinical standpoint, from a pre-op standpoint, from, day of surgery, and from a post-op perspective, looking at the technology you have as well, looking at, the fit from your ASC from a build-out standpoint. Is it designed, to be able to handle the cardio and the ortho, et cetera? And overall, really creating a patient experience here. We hear everything from amazing patient experience to, I feel like the surgery was good, but when I left, I didn't know what to do or where to go. I was confused. I had a bad experience post, and then that sort of leaves people, with either a very good or bad taste. So really, I think overarching as you're attacking this is thinking about it, from a patient experience perspective. To that point, a patient outreach program, how do you build and grow? Assuming you've got the surgeons and you've got the technology and you've gone through the, you've got a good, playbook on how to do this. How do we move patients? How do we get more patients into the surgery center that maybe historically have been going, to the hospital? And so I think there's an education that happens with the physician office. When I mentioned briefly I had the surgery, I think back to the day when I was in the doctor's office and they just turned to me and asked, do you want to have this done in a hospital or do you want to have it done in the ASC? With nothing, that was just the question. There wasn't education, there wasn't information on, what's going to be my patient financial responsibility, do they have a good track record? Have they done a lot of these? What are the advantages of an ASC versus the hospital? Pros and cons. Not even to sell, but just to inform and educate. So I think that's a missing piece that we see a lot across the country that I think there's significant opportunity there. From a more marketing perspective, having websites with patient testimonials and success stories there, having, a social media outreach program and designed, to educate with podcasts and, interviews and such are very powerful. And everyone has good relationships with their, medical device and implant companies. And a lot of those organizations have significant budgets to help you now that you've invested, in their technology to help you reach out and really build your base of patients and let them know that you've invested in this great technology, you have the best surgeons, and you've really been thoughtful about how to build this and explain to people why that makes sense to go there. Then the next step would be, and I'm not going to get into this in depth because Scott has sort of a major area here. He's going to go into much greater depth, but negotiating your managed care contracts for these areas, again, historically, a lot of these more interesting and complex procedures, your contracts are going to be silent to them or might have, very dated reimbursement or just ineffective in terms of the language there as it relates to these kinds of procedures. So really looking at your contracts, what you have, and then diving into that in depth. And again, Scott's going to go into that in more detail. In terms of your front end process, so important that we've got really good processes from the standpoint of addressing basically, does the patient meet those pre-surgery requirements? Have you do you have a good process to get a pre-auth for your insurance verification, for getting all the demographic information in correctly, understanding the payer's medical policies, having a good, assignment of benefit and good registration packet for the patient so that you're ready on the back end, you don't have to bother them, and that you can really have everything that you need to be able to ensure that on the back end you're going to get payment. You're investing a lot to go down this path. You're investing a lot in the front end from a technology standpoint, and you're investing in, the implants are expensive. All of those types of things. You want to make sure you've got a really good, process. The next step, that financial counseling, I'd mentioned it sort of briefly, but having someone to talk through someone on how this works, again, educating them on, from a financial perspective, that maybe this would save them 50% relative to doing it somewhere else, making sure you're getting paid up front, those types of things. And then jumping to the revenue cycle process, again, it's the same thing. You spent all this time, effort, and money to build a best practice clinically, to have all these processes in place. You need to make sure you get paid. So you've got to have strong coders who understand these different specialties, and specifically these different specialties that you're going after. Coding it incorrectly will absolutely lead to denials or underpayments, or it could be overpayments, which is obviously a compliance issue on the other end. Implant billing is a huge challenge and problem as we see across the country, and again, big dollars lost and left on the table from that standpoint. Having a really tight process for your AR and your denial management from that standpoint, and then having analytics that are built all around that provide you with really detailed daily, weekly, monthly reports so that you can track the performance of those specialties, that you have KPIs on your days to bill, for your case, and as it relates to your implants. So what's your cash per case? What's your denial rate? How many implants are sitting out there that haven't gotten paid? Because again, those are big dollars. And so anyways, again, all of this are significant, more information here, but with that, those are the big picture steps you really want to be thinking about. With that, I'm going to turn it to Scott, who's going to dive more into depth on the managed care contract side of it.
Thank you, Nader. So for this portion, I wanted to kind of start with basic information and knowledge, and then work towards more complex methodology and discussion. This first slide is pretty simple, organizing and managing your contract. We added this because we find it's often overlooked. Most ASCs don't have a specialized managed care team on staff to manage the contracts, much less go out and negotiate higher contracts. So we find it's very important to make sure that you have complete contracts on file. You know where they are, right? Any missing amendments, anything that could be important to that final reimbursement has to be gathered, analyzed. Then we want you to take that contract and language and really look at every point of the rev cycle. As Nader said in the last slide, starting with even the front desk and prior to surgery. Some contracts will dictate pre-surgery requirements. So for example, if you are wanting to do spine surgery and you start doing some spine surgeries there, fusions or whatever else, what could happen is the payer audits those cases. They can come back 6 months, a year later, and say, look, we looked at this, we found out that you were not following the pre-surgery protocol. Therefore, we're going to audit and take back that money. And so it's a very serious. It's very serious to have that on file. In addition to that, understanding the payer's policy on adding these specialized programs, right? The payer will sometimes have language that will dictate exactly, what goes into your total joint program or what's required from a clinical perspective to perform that surgery. And so just know the payer does look for that. In addition to those more important things for this topic, simple stuff like days to pay claims, how to submit implants properly, these are things that we find are often overlooked because the contracts are usually not organized and usually in a box sitting, not complete. And so we want you to get them out and really, do your homework here to review them and then put together some sort of metrics or a spreadsheet that details these important KPIs within your contracts, so you know how these new complex procedures will pay when you get them. And this is just kind of the organizing process. We're going to get into, once you have the contracts organized, kind of what will be your next steps. But This is a big issue, right? We see this a lot where just not having the complete contract on file is half the battle. And then going out and working with the payer to try to gather that information is also kind of a pain as well. Next slide, please. So once you've gathered your contracts and read through them, these are some of the reimbursement methodologies that you may encounter. This is not everything we see in the ASC world, but these sorts of methodologies is really what makes the ASC environment more difficult, right? Every payer kind of has their own way of doing things. So if you have a certain implant cost or procedure overhead cost, you have to kind of fit what you're doing into what they want you to and how they want you to be reimbursed for that. So for example, I'm sure a lot of you are familiar with groupers. Groupers, stem from Medicare. You basically get paid per grouper 1 through 9. They have a crosswalk that you associate the code to the group. Fairly simple. So for these contracts, if I was looking to carve out or get paid for, some of these high-end surgeries, total joint, spine, if my grouper contract only goes up, let's say group 9 only goes up to $3,000, and there's no additional payment for implants, cost plus or whatever else, you'd have to go into there and carve out, get some sort of allowance built in that contract for those higher cost procedures, right? There's a lot of things that are being performed, especially in this category, that are well over that $3,000 mark. And payers that utilize groupers, we have some payers that like to pay implants, a cost plus structure. Some payers want you to utilize a third-party company, and other payers that utilize grouper methodology, they just don't pay implants at all, right? So in that case, you'd have to go through and look at each one of these cases to understand what your overhead cost is, and then build in that into an implant carve-out or high-end procedure carve-out. The problem with that is you can imagine doing these complex cases, what kind of equipment you use, the coding that's used, the code combinations, it all changes, right? So you'd have to do your homework to understand what the common practice patterns were for that physician or group to make sure that you can that you get a solid carve-out in place. Moving down the list here to more of a Medicare-based methodology. So you may encounter payers that utilize APGs or APCs. They may advertise as just Medicare percentage of. They may have their own proprietary version of APG. It's important to note that some of these like to try to include that implant value into the procedure reimbursement. So just be mindful when you're reviewing those sorts of contracts. EAPG is a 3M product. Basically, it stands for Enhanced Ambulatory Payment Groups. We're seeing this really grow across the country. A lot of state work comp, Medicaid plans are purchasing this methodology and utilizing it. It utilizes a packaging system, so almost like an edit system where codes would be packaged together depending on what kind of procedure was being performed. And then you have finally, pretty common percentage of bill charges. Seems easy, but occasionally you'll see where payers will put in thresholds, or they'll have some sort of second adjudication method to protect them from, percentage of bill charge straight up. And so this is important because I wanted to point this out, because when people come into the ASC environment, they want to move through these payer contracts quickly, but they have to understand that the payers have these antiquated adjudication systems in place, and they want you to utilize how they pay. So once you get your contracts organized, you get them laid out, this is kind of the first step to understanding them. Next slide, please. Then we're going to move on to how you further analyze your contracts, right? You want to understand, what's making sense for you, what's not making sense. Nader had a couple slides previously in the presentation where we showed you some estimated reimbursements. I wanted to point out that those estimated reimbursements were just the primary procedure code only. So it's very common for ASC administrators, business office, to take maybe the top 20 or 30 codes, they'll throw them in a spreadsheet, they'll put in Medicare, and they'll think that makes sense, right? Reimbursement looks good, everything's paying well, right? This slide really focuses on, what you should be doing to make sure that you're accurately accounting for the full case, right? We want to know how not just the primary code pays, but we want to know how that full case would pay with the implants, modifiers, code combinations, all that fun stuff, right? So the case analysis is a great tool to do that. One of the key points within the contract that you'll want to identify to make sure this makes sense for you is the multiple procedure logic, and that is a term that basically is how that payer will pay or adjudicate multiple procedure codes in one case. So Medicare standard is 150/50, et cetera. They pay on everything, right? Other payers, commercial payers, may limit the amount of lines and the percentage of reimbursement on those lines. So for example, you may have a payer that may only pay you one line, or they may pay one line at 100% and one line at 50%, and then one at 25%. So kind of undercutting what Medicare's standard is, if you will. So once you understand kind of where your payers are, you want to start to gather cases, right? You can gather your top 10 cases, you can gather a couple thousand cases, whatever you feel like you want to look at, but the more the better, of course. The idea is to take all those cases and fully adjudicate them as if the payer was going to pay that case. The reason why is because you can really see exactly what that bottom line number is going to be, first of all, and then take that data and start to blow in your overhead costs, right? Maybe it's your per hour OR time. Maybe it's extra equipment that was utilized during that surgery. And for these types of surgeries, spine, cardio, total joints, we see a lot of experimental devices, drugs, heavy equipment that's used, and this all has to be accounted for, right? The reimbursement that you're getting for the ASC is the facility overhead, right? So we really want to do our homework, looking at the case analysis, determining what your overhead cost is, to come up with that final number to say, look, this is what we should be paid to make money on this case. And of course, doing that 1,000 times, the more the better, right? Next slide. So once you have your information gathered and you have identified your areas of weakness, after reviewing your case analysis, maybe you determine that your spine cases are well below Medicare, or maybe that your ortho procedures, these 3 or 4, are not paying very well, but these other ones are paying fine. So you want to get that data together, and the idea is to develop a kind of an informational packet for that payer. I think the days of just sending the payer an email and asking for X, Y, Z, it's definitely over. You have to make sure that you do your homework and you present that payer with solid information, right? So going through a couple of these, not only do we want to show the payer exactly what's not making sense currently, right? But we also want to show them what could happen if we get the right rate in place. For example, if you're a center and you want to bring in a new spine doctor or a new cardio doctor, including that physician's information into negotiations, and maybe even their case data into that negotiation as well, is very powerful, right? I think everybody's familiar with the great leverage point of migrating cases over from a higher cost setting to a lower cost ASC. That's perfect, right? But to have data to back that argument up and show them exactly how many cases you can potentially migrate over, who those providers are, that's even better, right? And if we can add on an additional layer to that and look at anything that makes your ASC unique in the area, maybe it's location, maybe it's your physicians are board certified, part of a certain association, maybe it's your technology, right? Maybe you're next door or on a hospital campus, right? These are all things that I think the payer should know about, as well as the numbers and the rates and the reimbursement. Doing these extra steps are very helpful when trying to secure some of the reimbursement for some of these higher cost procedures. And I think even more so with the cardio, the spine, and the total joints, this preparation, this homework is going to be crucial, because the payer may come back to you and ask you exactly, what are some of your policies in place, what kind of expected case movement can we see if we sign at this rate, and so all this is going to be important data when you're determining that final contract. So a question I usually get would be, how do you reach out to the payer? What are the next steps? How do I find this person? So, the local payer representative that you have, you should have somebody that represents that payer locally. Could be a local by your county or city. If you're a larger state, you may have 3 or 4 for the state. If it's a small state, you could only have 1 or 2 ASC reps. But you're going to want to make sure that that you know who that person is, and that you are emailing them, throughout the year when anything comes up. Could be maybe a case or a claim issue, but definitely at this point, when you're prepared with, getting higher rates, this is the time to go out to them and say, look, we have the situation. I have these 5 or 10 cases right now that we want to perform that are not being paid very well, and we want to move on them, right? Or maybe you're an eye center, as I said before, and you want to start doing ortho. This calls for, a whole reconstruction of your managed care contract, right? Carve-outs, implant reimbursement, whatever that is. As I said before, you want to definitely provide data to support your case. You want to have a thorough argument well beyond just an email asking for a higher rate. And I think doing your homework as well. Nader touched previously on the front desk. If you could have the front desk to start to track employers, really look at cases not making it to the ASC, any outcome data you have, right? These are all additional tools that can be helpful when working with that payer. In addition to that, if you have portal access, you can use that sometimes to communicate with that payer rep or try to get somebody to respond to your needs. I will tell you that once you identify that payer, the local payer rep, you want to work with them and provide them the data to bring to their board meeting. I think ultimately, if you can work with that person to reach the next step or higher level, that's how you want to do it. It's tough sometimes going around somebody like this at a local level, because what will happen is, and oftentimes the person that you reach out to, maybe it's a VP or director, they're going to circle back and add this person back into the conversation. So best bet's to play nice with this person and work with them until you get to a roadblock and then move on. So these are some of the payment model trends that we see that could impact migrating these sorts of procedures to your ASC. Traditionally, and I went through a lot of the fee-for-service. Fee-for-service is kind of the historical way that we see these programs being designed. This would be, essentially a carve-out rate or implant cost plus. Basically, you perform procedure, you get paid for it. So very simple. This would generally include the ASC overhead only. It may include additional implants, et cetera, but generally the ASC only. Bundle payment, I know this is a hot word around, hot topic for sure. Bundle payment programs are definitely here to stay, and I think it gives the payer, the employer, whoever's paying that bill, it gives them a little extra room to save money. And what I want to make sure to take note here is that these bundle payment programs, they can be designed in many different ways, right? You could have a bundle payment program that only includes the ASC facility overhead. It could be a bundle payments program that includes the physician and anesthesia. It could even be one that would include a 90-day global period and PT as well. So when you're working with a payer on adding these high-cost procedures, with total joints especially, you may encounter this bundled payment, or the payer may come back to you and say, look, this is the way that we're doing these procedures, and you have to abide by this bundled payment program. For example, Blue Cross of Michigan right now, a couple of years ago, they launched a total joint program, bundled program as well, and so you have to, if you want to take part in that program, you have to adopt their policies around that program as well. Just make sure that when you're doing your case analysis, if you are approached with a bundled payment program, case analysis has to include the anesthesia, professional overhead, PT, so you're just kind of adding on more layers to your analysis. Value-based care, this is, I think, a more up-and-coming payment model. I think we're going to see more of this, you know, it is how it sounds, right? Pretty much you're going to have a dollar amount assigned, and, you know, care is going to be based off of success, outcome, and so even more so your homework of doing the case analysis, understanding your code combinations, what the bottom line is and what your overhead cost is will be crucial if you were to venture into that arena for sure. And then, you know, this kind of blends into all of these. I think, as everyone knows, the employer right now is controlling a lot of the spend. So the employers are like to do direct deals with health systems and even ASCs. We had a direct employer deal just recently with a GI center and a casino. Casino patients had no out-of-pocket, bundled payment model, and so it was a win-win for both parties. We were able to increase the center's case amount and create happy patients and lower the employer's cost. So this isn't everything we're going to encounter, but these are some of the main model trends that we're seeing impacting those three big procedures. And so the last slide here, I know we kind of went over some of this already. I just wanted to kind of retouch on you know, when you're looking at these three especially, I think doing your homework to make sure you have everything covered is going to be crucial. Looking at your implant costs, looking at how that payer wants the implant to be billed, right? Do they want you to bill it at invoice cost plus? Is it a carve-out rate? Are they paying you invoice cost? Are you having to submit it through an IPG, a third-party implant vendor? So these are all questions you want to ask before moving forward. And then lastly, I think, you know, this is something that can quickly add to your bottom line. Quick case study. We had a client down in Florida actually that was they were successful in adding two of the big three surgeries to their ASC. Of course, you know, the contracts were not designed for these procedures. We had to go in and work with all the payers to carve out, create carve-outs, request for implant coverage, whatever it was, to get these moved over. But almost a month after that, we were able to increase that ASC's bottom line quite a bit by adding on, you know, a couple of, you know, $20,000 or $30,000 cases.
Great. Thanks, Scott. So jumping in and sort of being cognizant of the time here, I guess the most I shouldn't say the most important. One of the very important points here is the financial impact on your surgery center. And so we've just done an illustrative pro forma example of the financial impact here on your left. So taking as some base assumptions that you would have a surgery center that's doing 300 cases a month, a multi-specialty surgery center, with $2,000 as an average cash per case, so therefore generating about $600,000 a month in collections, and EBITDA margin using an average of about 20% for the margin, $120,000. So that annualizes, that surgery center would look like a $7.2 million, you know, annualized revenue business with $1.44 million of EBITDA, and a business like that that's sort of solid, steady in this industry. There's a range, and a lot of things can impact your multiples, but using 7 times is a pretty fair average for a business like that. So that organization would be worth about $10.1 million, which is great. So thinking about the reimbursement that we were talking about, as you've seen earlier in the presentation, be it ortho, spine, cardio, all, you know, pretty significant in terms of the reimbursement, and again, our experience also in terms of the profit. So we see those at many of those north of 50% margin type procedures. But so we use an assumption here of 50% for your margin. So if you do nothing but add 30 cases a month, so you're adding 10% volume to your surgery center, going from 300 to 330 cases a month, and using, and I think somewhat conservatively, a cash per case of $11,000. Now, obviously, that depends on your mix, but you saw some of those cases were 25 to 30,000, some were 2 to 4,000. So, again, on a somewhat conservative basis, if you were going to look at ortho, cardio, spine, $11,000 cash per case for these new cases. And in that scenario, you're looking at that would generate $330,000 a month of additional revenue, and at a 50% margin, another $165,000 per month. So again, annualize those new numbers. So your new numbers, just for these 30 cases, would be $3.96 million and $1.98 million of EBITDA. So now we combine the entity. We take what we were doing before. We've added these 30 cases. We now have an organization that's gone from $7.2 million to $11.16 million with these additional 30 cases a month. But look at the impact to that bottom line to your EBITDA. You went from a $1.4 million EBITDA, and by the way, in the event, EBITDA isn't a known term. It's earning before interest, taxes, depreciation, amortization, otherwise kind of a proxy for your cash flow. So looking at that from a cash flow standpoint or margin, cash flow margin, you've gone from $1.4 million to $3.42 million in EBITDA. And now, if you look here, I say combined equity value at 10 times. Why did I change it from 7 to 10? Not just to make my example look better, but because you've changed the profile of your organization to someone who would look at this from the outside. You would all of a sudden go from a solid, steady Eddie surgery center generating nice cash flow and a good, solid business to a rapidly growing, high margin business. You know, you're looking at a 30+% margin business there. So you've cranked up your margin and you are part of the future. So whether you're a private equity firm, health systems, whomever it is looking at this, those are the things that really drive it. So frankly, 10 times is, not overly aggressive for that. I would say I've seen, 9 to 12 times if that's kind of the profile of your business. So in this scenario, 10 times, you've all of a sudden now, your $10.1 million business is worth $34.2 million by adding 30 cases a month of these kinds of specialties. So you've had a $24 million increase in your equity value. It is very, very hard to find any opportunity in life to triple your net worth by adding 10% additional volume to whatever you were doing. It's again, a rare opportunity, in the business world. And so something that, again, I think everyone should really think about. So just really quickly, to the next slide, in terms of options, if you do that, if that's what your business looks like, you're in a wonderful position to remain standalone, continue to fund your own growth through your cash flow, and continue to operate as you always have if you're independent. You've got an opportunity to partner with a local hospital. They're going to be very excited about the movement of that and seeing those numbers. And obviously that's an opportunity to increase your referral base, work nicely with the local health system, et cetera. And another option is there's a very active movement in surgery centers, and particularly with these surgery centers that have these specialties, where private equity firms are coming out of the woodwork and will be much more aggressively so over the next couple of years, because they love high cash flow generating, high growth businesses that service a very important need, which is healthcare, and specifically reducing healthcare costs. So anyways, with all of that, we open it up to, I think we have 5 minutes for questions and answers.
Well, thank you, Nader and Scott, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. And Nader and Scott, we do have a few questions here ready to go. So first off, what are the main factors that will impact the valuation multiple that I should get for my ASC?
Laura, I briefly hit on that at the end, and so really it is, at the end of the day, it is what's driving your growth rate and your margin is going to move that multiple up. And so your specialty mix is important, but it's important because from an investor perspective, it's going to drive up those two main numbers. So if you can get your revenue to grow, at 20% a year and your bottom line to grow at 20 to 30% a year, you'll be highly attractive to the outside world relative to someone that's sort of, generally flat to 5% growth. And that's where your multiples go from 7 times EBITDA to 10 to 12 times.
Got it. Thank you so much for clarifying that. Our next question, the attendee wants to know, her center is denied access to go in-network. How can I appeal, and what type of data should I use?
Yeah, I'll get that one. This is Scott. So I think the question was, I'm trying to go in-network but being denied access to the payer network, correct?
Yeah. Yep.
Okay. Yeah, so this is a common issue we see, and I think what happens is we find that the ASC may have not provided that payer or that board with enough information to make the right decision. I will say that your region and market saturation will definitely play a role, but if you do your homework and you have a good case, a good story to tell with the physicians and the cases you can bring over to that lower cost setting, I think you have to prepare that into a formal document to present at the next board meeting to that payer.
Perfect, and thank you so much for going through all that with us. I appreciate it. The next attendee question we have is, will the commercial payer cover additional items not considered to be implantable devices but add significant cost to procedure or overhead?
Did you hear that? Sorry, Laura, I was having a little bit of a hard time hearing it.
Sure. Let me try again. So the next question is, will the commercial payer cover additional items not considered to be implantable devices but do add significant cost to the procedure or overhead?
Yeah, that's a great question. They absolutely will, but you have to include that into a set carve-out or the reimbursement for that facility overhead. So some of these more common ones would be like extended care hours, right? Maybe you wanted to have an area where the patient can go hang out after surgery. That's one. I think another one would be, any sort of injectables. Right now, I think, the PRPs and the things that are not really deemed payable yet by all the payers. Yeah, absolutely. In addition to that, anything like any sort of large equipment rentals or whatever, we always like to include that into that overhead cost. So that's why I think if developing some sort of per hour OR time and then utilizing your preference cards and the system to determine how long these surgeries are taken, then developing your what your bottom line number is. Yeah, good question. Thanks.
Absolutely. That's a really interesting point. And the next attendee question I have here is, can I do total joints out of network and what are my risks?
Yeah, you absolutely can do total joints out of network. We didn't get a lot into the out of network discussion in this presentation, but I will say that make sure that you understand who the employer is and how that claim will adjudicate out of network. I think, making sure you're doing your due diligence up front, pre-auth, verification, all of those bells and whistles before seeing that patient. And we could probably do a whole other presentation on just how to handle that patient after that care is given.
Fantastic. Well, Nader and Scott, do you have any final thoughts?
No, if you have any last questions, we're happy to answer. Obviously, we are super excited about what's happening in the market, and obviously, if anyone has any follow-up questions relative to this or anything that we talked about today, we're very happy to take anyone's follow-up question.
Well, thank you so much. That's all the time we have for today. I want to thank Nader and Scott for their excellent presentation and National Medical Billing Services for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.